We're going to move on to the next fast debate and the last one of this first block. We are going to ask Dr. Jaime Ponce and Dr. Enrique Arias to come here. We are going to speak about sleeve failure. Dr. Jaime Ponce is going to talk about after sleeve failure, Roux-en-Y gastric bypass, and Dr. Enrique Arias, SADIS. You can begin.
So thank you very much. Thank you, Nathan, and congratulations for putting this meeting together today. So my position is going to defend that Roux-en-Y gastric bypass is a better option than SADI after a failed sleeve gastrectomy. You have the...
I don't have.
The remote.
So the question here is Roux-en-Y versus SADI. So it's very nice picture when you convert the sleeve to a bypass. Very nice picture when you convert the sleeve to a SADI. Now the problem with this picture, the second one converted to SADI, is that you need to have, in order to convert it to a SADI, you need to preserve that sleeve pouch. So that sleeve pouch has to be very nice, has to be in perfect condition in order for you to be able to do a SADI. So I would assume that my opponent is not going to argue with me that converting to a SADI on this situation is not indicated. So if you have a sleeve damage with stenosis, kinks, or any complications, you probably are going to prefer to do a Roux-en-Y gastric bypass instead of leaving that pouch there for a SADI. Even in these cases in which you have reflux, my opponent is probably still going to agree with me, I would assume so, that in cases of reflux, he's not going to leave that pouch and continue to have more reflux and more complications. So I guess on these cases, we're not going to have a lot of argument in regards to complications from the sleeve pouch. And in those cases, you probably are going to agree with me. Now, you probably are going to show me data that in regards to weight loss, you're going to have a little stronger proposition. Well, there's a couple of meta-analyses that I wanted to just summarize for you. You probably are you've seen this, but this is a meta-analysis of all the conversions from Roux-en-Y gastric bypass to a sleeve gastrectomy, published just July this year. And so it's pretty recent, 17 studies, 550 patients, very typical patients. Now, 1/3 of the patients are converted for reflux. Again, those cases you probably are not going to argue with me because the Roux-en-Y gastric bypass is a better option than the SADI. But 50% of those patients are converted for poor weight loss or weight regain. Those are the ones that we're going to be arguing. And you probably are not going to argue with all the complications that are also converted to Roux-en-Y gastric bypass, which is stenosis, torsion, or other mechanical complications. In regards to comorbidity resolutions, I can show you that the Roux-en-Y gastric bypass is very effective to resolve the reflux, to improve the type 2 diabetes, and this is according to this meta-analysis. And in regards to weight loss outcomes, it's pretty decent, obtaining 40% at 12 months. This is it's available in the literature. Now, they also talk in this meta-analysis about the weight loss that you may get with BPD and DS. Notice that I say BPD and DS and not SADI because that's what this meta-analysis shows. So don't come and tell me that that's the same weight loss that you're going to get with SADI unless you have something to prove it with. But the other problem is that every time that you convert it to a DS in this paper, it shows that you have higher incidence of complications. So now it comes an issue about risk and benefits. You're gonna try to get some better outcomes at the expense of more risks and more reoperations and more problems. Now, there is a meta-analysis that hopefully you review that it was published comparing the Roux-en-Y with SADI to as a second stage to resolve a sleeve gastrectomy problems. In this meta-analysis, the problem is that it's only including 6 retrospective cohort studies. And out of those 6 studies, only 2 studies talk about SADI versus bypass. The other 4 studies talk about BPD-DS. But even if you include the 6 studies, weight loss favors the BPD-DS group. But when you look at only those two papers, which I extracted from the meta-analysis, one paper, the weight loss is pretty similar, extremely similar. So really, the conclusion of this meta-analysis is that there is very insufficient data. You don't have very good data to express or to define that there is a big difference in regards to the weight loss. So, to me, hopefully you want to argue with me that converting a sleeve gastrectomy for anatomic problems or reflux goes to a Roux-en-Y. Even when you have poor weight loss with reflux, you're probably still going to go to Roux-en-Y. And the question is, when there is no reflux and no weight loss, you have to still look at risk and balance. So still some patients may not necessarily need to go to more risk for the benefit that they're going to get. Thank you.
Thank you. Enrique?
Good morning, everyone. Could you please play my slide, please? Thank you. I would like to thank the organizer for inviting me to present today. Second, for giving me the better procedure to uphold. SADIS is a better option for patients with a sleeve gastrectomy after weight regain, and I will explain today why this is. But also I have a public complaint for them because they changed my opponent last minute. They choose one of the most famous bariatric surgeons, and also they changed the topic because it's supposed to be one anastomosis gastric bypass, and they changed for Roux-en-Y gastric bypass. But that means that SADIS by itself is stronger, and it doesn't need my explanation to be the winner of this debate. First,
not my fault.
First, what do we know about SADIS? SADIS was introduced in 2007 by Dr. Sanchez Pernaut, and was accepted as a modification of duodenal switch. And is a single anastomosis duodenal ileal bypass with similar weight loss and metabolic result with a lower complication rate, and also is named a single anastomosis loop duodenal switch, also stomach ileal pylorus preserving surgery, but it's the same procedure. This procedure preserves the pylorus and has many advantages for this reason, and also is a procedure that is adopted for many surgeons around the world, and maybe will be the bariatric gold standard procedure at the near future. But you can see here the SADIS with the single anastomosis and 300 centimeters common limbs, and you can see here the excess of weight loss near 90% after 2 years. Also the metabolic effects, you can see here almost all the diabetic patients are not using any medication after 5 years. But what do we know about SADIS after sleeve gastrectomy? Here you can see a lot of papers explaining the result after convert a sleeve gastrectomy to SADIS, and you can conclude that SADIS is offer a satisfactory weight loss and similar metabolic effects with lesser complication rates of duodenal switch. And what is the evidence? We have some papers explaining that. You can find, I hope Dr. Professor Ponce read this paper, and you can see here a multi-institutional revision. This is a paper that explains that SADIS report excess of weight loss of 64 after 1 year and diabetic remission rate of 93%. The conclusion was the SADIS is an effective weight loss option for a sleeve gastrectomy weight regain patient and has a less complication rate than duodenal switch. But what do we know about SADIS versus Roux-en-Y gastric bypass? That is the topic of this debate. Here you have the data about the duodenal switch has 80% of weight loss, and Roux-en-Y has 65%. And also comorbidity resolution is better for duodenal switch. I know that Dr. Ponce will explain you that this is duodenal switch, not SADIS, but you have many papers explain you that duodenal switch and SADIS has similar weight loss and metabolic effects, but with lesser complication and a easier technique. Here is another paper. This is comparison of Roux-en-Y gastric bypass versus SADIS, and also has SADIS better results than Roux-en-Y gastric bypass, 88% of weight loss versus 78. And also with a patient above 55 of BMI, SADIS was better. And then we have another papers of coming from China with patient above 35. This is a paper coming this year. It's only online publication, and these have better results for SADIS than Roux-en-Y gastric bypass. This is the evidence. You can find a lot of evidence telling that, but this is our experience with SADIS. We convert 22 patients from sleeve gastrectomy to SADIS, and we have 80% of excess weight loss and 87% of comorbidity resolution. And I only have I explain you a variant that we have to super for convince that SADIS is a good procedure. Now, the first one is the technique that I think that is the most important point because surgeons don't want to perform SADIS around the world.
Thank you, Enrique. I'm going to give you 1 minute each other, please.
Yeah, I mean, it's interesting that you, of course, you didn't address the fact that for reflux and for sleeve pouch problems, you know, you probably are going to support the Roux-en-Y gastric bypass. So I guess you agree with me on that part. Second thing is, you didn't mention anything about the risk of the SADI procedure. You also show us the benefits and the potential benefits on comorbidities, which actually, when you compare those numbers, you know, you're talking about 10, 20% difference some of the comorbidities, but you don't talk about the risk, which is also a 10 to 20% difference in complications.
Yes, first, well, if you are talking about the complication after sleep, I am agree with you that you have to convert for reflux. Reflux is a complication after sleep. Then I am agree with you that gastric bypass, Roux-en-Y is a better option. But if I am talking about the weight regain, SADIS is a better option. Now you are talking about the technical implication of SADIS, and I think that if you are able to perform a Roux-en-Y gastric bypass, you will be able to perform a SADIS. It's a technique that you only have to improve the duodenal dissection and be carefully with take the size of the common channel because you have to use a marker grasper or a ruler, because if you do the same way to perform this size at the same weight of Roux-en-Y gastric bypass, you can have a shorter channel, shorter common channel, and you will be in trouble. Thank you.
I have a concern about SADIS. What about the duodeno-ileal anastomosis? I think is has more risk than the other one. And why?
If you review the literature, it's not true because it has the same complication rate of Roux-en-Y gastric bypass. If you are able to perform a Roux-en-Y gastric bypass, you can do a duodenal ileal anastomosis. It's not difference. The only difference is the dissection of the duodenum. You be careful, but if you take the ability to do that, you can do the SADIS, and SADIS has better results in weight loss for patients with a sleeve gastrectomy weight regain.
And remember, it's not only about technical complications, it's also about the nutritional deficiencies that you can have over time.
What about the metabolic effects of?
But you don't have the same malnutritional effects with SADIS than with duodenal switch. We have papers showing that the SADIS is a better procedure. This is the reason because somebody changed the 200 centimeters to 300 centimeters SADIS. I agree with you that if you perform the SADIS with 200 centimeters, you will have malnutritional effects. And this is the reason because in Latin America, somebody avoid to perform SADIS because they count the from the ilion cecal valve and they do the same weight of Roux-en-Y gastric bypass. And when you use a ruler, you see that the distance was shorter than they was expected. And this is the reason because we have malnutritional effects. If we use 300 centimeters, we don't have malnutritional effects.
I have two questions from the public. The physiological gut hormone changes are similar after sleeve and Roux-en-Y, so probably makes more sense to do a one anastomosis gastric bypass or SADIS after sleeve rather than Roux-en-Y for poor weight loss. What do you think about that, Jaime?
So it's better to do a one
One
anastomosis
anastomosis
gastric
SADIS instead of Roux-en-Y
because of why?
because of the gut hormone changes.
I mean, you have. I don't know if there's anything in the literature or has proven that there is a big difference in the gut hormones changes in between the two procedures. You know, certainly you have more stronger metabolic effect when you do a duodenal switch. The data on SADI is still not very strong and validated. You know, they're all retrospective cohort studies. We need to do a randomized clinical trial. We also need to compare the study with the duodenal switch to understand the difference in between those two. I do think that the study has a lot of potential, and I agree with you, independent of the debate. You know, I think the study has a lot of potential, and it's a good procedure, and it potentially will solve a lot of the questions. But Roux-en-Y has many years and many randomized clinical trials to prove the effectiveness.
Totally agree. SADIS has the advantage of preserving the pylorus and has physiological advantage of that.
Okay.
Can I have a question?
I have a question. Very fast. If you let's take aside the Roux-en-Y. If you had only malabsorptive or disabsorptive procedure, which one would you choose? You have one anastomosis, SADIS, the DS, even they are asking Santoro, all those options. Which one will you do if we take aside the Roux-en-Y?
No, that's a good question because I think I will start with something that is less invasive considering the data that we have. You know, I think the SADI, I would probably go with the SADI before I go with the duodenal switch.
Felipe, you have a question.
Hello. You're gonna do a Roux-en-Y after sleeve. Do you do the same BP limb length and elementary limb for reflux, for weight regain? I mean, gonna be different. What are the lengths that you're gonna?
Yeah, I mean, there's a lot of controversy. So if you really are trying to address reflux, you know, you probably need to have, you know, decent size in the Roux limb. But you do the Roux-en-Y gastric bypass like you would do with anybody else. You know, you wanted to implement more weight loss, and I think there is now data that if you leave a longer BP limb,
Not for weight loss, just for
reflux, just a decent size, you know.
For regain.
At least 75 centimeters, if not more. For weight regain, I will go with a longer BP limb.
Thank you. Thank you very much to both of you.
So this is gonna be the final remarks. Thank you very much to you all for listening, for being present here. It has been hard for us to try to arrange all of this, but we are done. So let's continue. 9:30, we almost end. Thank you very much. Next issue.